Hi, I'm Terry Arnold for the IBC Network Foundation, and we're doing a podcast called Talk IBC. And I'm so delighted to have Dr. Naoto Ueno with me just before he leaves MD Anderson to go on a new adventure in Hawaii. Hello, Dr. Ueno.
Hi, nice to see you again, Terry.
I know we got to talk just the other day. I'm really going to miss you. I'm going to say it straight out. You have been so magnificent about being so accessible. But one of the things I know about you, since you're such an international person, you're going to still stay in touch. So that makes me feel a little bit better.
Good. I'm glad to hear that. I'm not completely disappearing, so that's good, actually.
No, you've got an amazing presence on social media. You are very, very accessible. But one of the things I really appreciate you, so I'm gonna get the little fan gush out of the way a little bit in the beginning. I really appreciate how much you value patient advocates and how open you are to new ideas and just what an open door policy you've had. I'm not saying other people don't have that, but I think you have it uniquely. And I've always selfishly kind of thought maybe it's because you've been a cancer patient yourself that it made you have a little different perspective. I'm going to talk about that. So before we get started too much, can you tell everybody what is your new adventure? Why are you leaving MD Anderson?
So I am leaving MD Anderson as of December the 9th, and I will be starting a new position at University of Hawaii Cancer Center as a director. So my position is leading NCI designated cancer center, which has a very diverse patient population, 40% Asian, 15-20% Native Hawaiians and Pacific Islander, and the rest is a mixed race, Caucasians and Black, less Hispanic. But it's very diverse. So that's the population with a different disease pattern. One of the interesting thing is because of the location, we have a very high rate of liver cancer. So my new job is to really provide the strategy for the Hawaii and the Pacific area. We are a small cancer center, but we have the world's largest catchment area to tackle health disparity issues, including access and information education. And then we really need to provide unique treatment that will benefit for the people who's living in state of Hawaii and the Pacific. So that's my new job.
I'm interrupting. I know you've been at MD Anderson a long time. What, 20 years?
Close to 30 years.
30. I knew it was a long time, so this is a big change for you. But I know I've watched your desire to address a particular population for a long time. So I think you're going to get to do something you've been talking about. I think it'd be very interesting for people to understand and have you explain this. I know we hear in the IBC world how women of color, mainly Black women, succumb to the disease much quicker. But the statistics about the Japanese or the Asian Pacificers are actually more severe. Is that correct?
That's correct. There's not a solid data about the impact to the people like Asian American Native Hawaiians, but we do have a Hawaii registry that to show that there's a higher rate of inflammatory breast cancer in Pacific Islander. And the second is that in Asian, it's not high, but they could behave more aggressively. So we don't know why, and that why is very important. And particularly Hawaii is in the position to do these unique research that cannot be performed at other places. For example, taking the Japanese demographic and starting from Japan, moving to Hawaii. Historically, that people from Japan moved to Hawaii, and then it moved to mainland. And as we move towards the east, the rate of the breast cancer goes up. And people talk about dietary and environmental changes, but it's not really well defined at the molecular level. And that's important to know, because if we understand this, it only not benefits from the Japanese American, but Asian community, Pacific Islander, and to even for people who live in mainland, because we still have yet to define what is the environment or dietary factor that's impacting, right? So it's really a good model to use to identify the things that we can't identify in the mainland area. So going
It's
back to
interesting. Oh, it's
go ahead.
interesting that you say this because I've been in this role since I was diagnosed 15 years ago. And um, when I meet someone from the Philippines,
Mhm,
I have noticed there's not that many, but what I've noticed, the disease is very aggressive
mhm,
and there's not that many survivors. So I can see why
mhm,
this question has been haunting you for a while. So
mhm.
you've gone from now the director of the Morgan Welch program to the director of the hospital. So that's a bigger
Well,
responsibility.
not the director of the hospital, director
Well,
of
I
the
wanted to give you a raise. I'm sorry, I'm trying.
cancer center oversees so it's not like MD Anderson that MD Anderson has its own hospital, but we are more of a typical um, cancer center in the nation. There's 71 NCI designated cancer center, and most places do not own a hospital. They're affiliated. So it's the same thing for us. We do have we have a collaborative effort with like Queens Hospital or Hawaii Pacific Healthcare or Quakinis and Castles. And so the goal here is to really provide care using the semi-academic and community setting that exist in Hawaii. So
Okay.
it's not like MD, it's not MD Anderson. Yeah.
Well, no, I think it's interesting. I want to address something really quick. I know we talked a couple of days ago about some of your plans, and I told you I think it surprised you. I had a few people contact me and say, "Wow, Ueno's leaving. I guess MD Anderson is closing their IBC department because you've been at the face of it for so many years now." But it was there before you. It will be there after you. The IBC program is not going away. The research is not stopping, but you are doing something that's going to allow us an opportunity to have one more place to fund. I would
Mhm.
love you to tell everybody about your plans for research in Hawaii.
So focusing on the IBC, as I just mentioned, that because of very different demographic and we have access to a very different patient population. So one of my top goals is to really understand the tumor microenvironment. Tumor microenvironment meaning that there's cancer and there's a surrounding changes, and we want to molecularly or immunologically define what are the changes that's happening. So we will be bringing in innovative technology to understand this, and that's the first step that we're going to be taking, and really revamp the registry so that we identify patient with IBC in that area. So that's my top research agenda by moving over there. The second is that my group, research group is moving, and we have a very strong research group that could develop novel treatment. And we may not have a large IBC clinic, and that's probably not going to be feasible considering the size of the state. However, I'm now completely exiting. I'm exiting as executive director. I'm exiting as a MD Anderson full-time faculty, but my goal is to maintain as a part-time faculty. And then also if we have ideas, we have new or existing great clinical faculty. So we will bring this idea to MD Anderson, or even recently working closely with Dana-Farber, so that
Mhm.
there's opportunity for access. But research is not simply is not location dependent. What's really more matter is the willingness to really come up with something exciting and innovative, and at the same time, are you willing to share this knowledge or experience with other locations? And I think I have enough track record that I do these things, and I do these things
Mhm.
from not just from as an individual investigator, but I'm also, quite seasoned administrator. So, and research is two factor goes in: innovation and really follow up through the details so that it happens by creating that right network. It's easy to say we network, but it does take a certain effort, and that's the thing that I would like to contribute by going to the next location.
I think that's really cool because, and it's good to hear you say that because I know in the beginning it was so hard to get me to talk about IBT at all. And
Mhm,
so I would really push, and other people would push for patients to go to MD Anderson, get close
mhm,
to research, go to Dana-Farber, get close to that research. But now that we see there is more research, not enough, anywhere near enough, there's a little bit
mhm,
more. and what to see these institutions working together. And
Mhm.
now we're going to have one more institution. And to me, if I've always been a big proponent of studying what is going on in our women of color, what is going on in our Filipinos, what is going on, because if we can stop a really aggressive form of cancer, it's like we could stop something slower. So all this is going to help us. And you're also going to be, as I understand, overseeing things in some of the territories. Is
Mhm.
that fair to say? For people
Uh,
maybe aren't in the different territories of the US, like
that is
Guam and such,
correct. So,
which is underserved.
right. So the catchment area is very diverse, and we have state of Hawaii serving 1.4 million people. But between Hawaii and Guam, there is different U.S. territory, and there is sovereignty nations that exist, and but they're all connected to Hawaii, and the Hawaii actually serve as a uh, geopolitical point so that we provide support to these area where healthcare access is not stellar, and and so you're right. So our goal is to make sure that regardless of the location, which actually applies to the concept that I've been interested in, one of the things that I will say that one of my accomplishments is to really how to provide the the care value regardless of the location, and that has been accomplished at probably domestically at the mainland, but now I'm coming to a stage that whether this could be applied in a much more challenging situations.
Well, it's interesting. We often think about access as the first point, but I was recently helping a man who lives in a very small town in the middle of nowhere. He and his wife, she had IBC, and things are looking good now. I'm glad, but she was getting really, really poor care. And I started looking into, I've heard Otis from American Cancer Society, he would say back in the day all the time, your zip code dictates the quality of care. I always thought that meant if you lived maybe you lived in a Houston or Chicago or New York, there's a lot there. But I also didn't realize it meant something on a different level. And I know this is probably not your place to talk, but something I want to talk about eventually is the way education works in medicine. There's community standards. I've been looking this stuff up and talking to a lot of lawyers. There's community standards, and the community can offer you the best they have. Obviously, if you need some kind of micro surgery, you're in the middle of nowhereville, they can't offer you that. And so what I'm seeing is IBC doctors are trying to pull up the community standard. It's much deeper conversation than just, do you live near a big city? Does your insurance let you go to major center? Is how do we pull up the education level to its best? Does that make any sense to what I just said?
So, yeah, so I think they all have some basic knowledge, and but knowledge and digesting the knowledge to implement that really meets the need of the patient's need is a little bit two different things. And so I think IBC has some challenges because the word IBC probably is recognized by most of the oncologists, and they probably know some of the basic guidelines of how it should be algorithm, how it should be treated. That doesn't mean that when you have a particular patient in front of you, can you make the diagnosis and can you really plan coming up with the right treatment and execute the treatment? That is a completely different story. So it is something that it requires education and system, and it's not always the knowledge that we already created. The knowledge we created is quite solid and it already exists, but whether you can make people to understand and implement takes a different level of commitment and smartness that's needed.
That's what I'm seeing, and it sent me down a whole rabbit hole of trying to understand, and it made Otis's statement. He's no longer American Cancer Society, but it made his statement even more deep to me. It wasn't just straight up access, Well, what I know that this project's been eating at you for a while, because I remember when you went through your second bout of cancer, you and I were texting back and forth when you were having that done. I don't know how much you want to talk about that now, but one thing I feel that's made you so unique with IBC patients is you've been a cancer survivor. And
Mhm.
so you know what it's like to be on the other side of that coat, I call it.
Mhm.
I remember
Yeah.
one day you texted me going, "Oh my gosh, I just paid 5 copays in one day. Is it always like this?" I don't know if you remember that, but I remember that
I
because you were
did.
frustrated. You're like, this is how do people do this? You know, do you want to talk about your experience as a cancer survivor? And like I said, as little or as
Well,
much as you want.
right. So it's really, I don't know where I should be starting point. There's many things I could talk, but the funny part is that, I'm doing well now. And as you go through that process, you actually lose the memory, and the memory is history is, you become a revisionist of your history, right? So that's something I learned through the process of being a patient. So what I wrote in Facebook on day-to-day basis and what I'm remembering is getting quite different. And so,
Isn't that interesting? Well, you're a
yeah,
fairly young man, so you were diagnosed the first time. You had to have been somewhat young because it was many years ago.
right. So what I'm trying to say here is, if I, as a patient, what did I learn? And one thing I learned is you have to be humble about your experience. And because now I'm, reasonably doing well, and there's still challenges I face, but overall, I could do what I want to do, right? And but then when I was actually going as a patient, the immense pressure and stress and anxiety is quite high, and you forget. And I think forgetting, I feel, is a good thing, actually, to a certain extent,
Mhm.
right? You don't want to be having a traumatic event. So as a physician working with like patient with IVC or patient who have disease that's not curable, it does make me think about, what is this patient thinking now, and what can I do, type of thing. Um, Sometimes, overlapping yourself with people who's talking to me could be quite painful. So I sometimes dissociate myself completely. It's not in a negative way, but I
Mhm.
can't completely, people talk about being empathetic, but when you do like myself with this, very severe situation, being empathetic could take a lot of energy out.
It's
And
interesting you say that because I had a patient once who wrote me and said, an IBC patient who wrote me and said she was frustrated her doctor didn't hug her. And her old doctor always hugged her. And I said, I don't know that we should expect our doctors to hug us. They
uh,
have to find a way to cope with this. You don't know what she just walked out of in that other room, or what self-protection she's having to go through. Or maybe a lot of people I meet that have gotten involved in heavy cancer was because they lost a parent or they lost a sibling. And so some pain launched their interest. I think we need to remember our doctors are human too, and give them a little room. I've gotten lazy about it lately. On my birthday, I would send my old doctors a thank you card that I
mhm.
got a bonus birthday because I can't imagine how discouraging it must be for them sometimes. Because they, I think, forget about the successes. But it's interesting to see how you have to back up a little bit to be a little bit self-protective, to do a good job,
Right,
just to do your job well.
right. And then, as the other thing I think I could say is, research does help. Research may not help you, but research ultimately helps somebody. So there is a strong commitment needed. And as a physician or as a patient, I strongly believe in research. But believing in research does not mean that you're always going to get the right outcome.
Mhm.
And then the infrastructure that we have at the hospital, and I'm not particularly focused on MD Anderson, there is a lot of issues. There's so much issue to the point that it is very frustrating. And the question is, how much energy do you spend to address those issues? And
Mhm.
of course, from patients' perspective, they said we should be spending like crazy to fix the issues. But I have to say that not everybody truly cares about every single issue that they're facing. And that's something that I see among the healthcare providers. And that's not because they're not interested, but it's just that they're burnout, and they don't have enough resiliency. And at the same time that, one of the example that I don't like to say is, what frustrates me as a healthcare provider is that people promising that they're not going to execute. So, I think we will get this done by like tomorrow. Don't worry about it. I'll take care of it. How often do we see this kind of statement from my colleagues or and they mean it, okay, but
But it's an unrealistic promise.
it is
It's
unrealistic.
an unrealistic promise.
Unrealistic promise, and it doesn't happen. And this is really probably, I get criticism because I say things, I don't like to say things that I can't deliver. And that's something probably it's impacted for myself as a being patient, because I hate people who saying things that they're not going to be able to execute. If you tell me something, give me reasonable expectation. But
I'm going to interrupt you because this is something I'm really bad about doing. I'm really bad about saying, "Oh, I'll get that to you tomorrow," because I really want to get it to them tomorrow. I really intend to get it to them tomorrow. I'm going to try to get it tomorrow. But something comes up and I get it to them 2 days later. And what I've gotten where I do is say, "Oh, give me 4 days or give me 3 days," because then if I get it to them early, they're not unhappy. And I could have given it to them 3 days and they'd be just as happy. But because I didn't give it to them in the 24 hours, they're stressed. And there's all these triggers going off. So I've had to make myself give a little, what I call room, a little bit of wiggle room. Just because sometimes I see patients all the time say, they tell me they'd have it tomorrow and they don't have it tomorrow. But it's there the next morning, but it doesn't matter. It wasn't tomorrow. And that's all they can see.
And it turns out that people who are more assertive, and whether it's right or wrong, they seem to sometimes score better, actually. And then if you're not, if you're willing to be a little bit not fuzzy about it, then you get you get criticism from the saying the doctor is not knowing what they want to do. But I really don't know what to say. And then so this is a dilemma that being a patient, having a extensive patient experience and being a physician. So I try to be extra careful about it. And even talking with a patient about supportive care or terminal care, I'm probably more realistic than any other people. And sometimes, you want to be empathetic and compassionate, but at the same time, there is this hesitation of to me, sometimes it feel like lying if I say that everything will be okay. Everything is not okay, there'll be
it's funny. I have people sometimes they'll write me and they'll say, "I have IBC. I don't know if I should go to a specialty center. I'll go when it gets bad." And I always tell them, "Well, hate to break it to you, but you have IBC. It is bad. So let's just face that reality." And I don't like to throw stats at people and just make them feel like a number. But and I do tell them, "I'm going to talk very straight with you about what's going on. I'm not going to blow smoke that this isn't a big deal, but I'm also not going to take away all your hope." And it's a constant balance. And you have to look at the person you're talking to. At least I get the opportunity to get to know them very well. Sometimes we, get to have meetups and things like that. I know you spend a lot of time with your patients, but it's still, it's hard to get to know them very well. And I can swear we are different people in that room in front of you because we're scared.
Absolutely. And then I don't think I will ever understand every single patient. And most patients, I probably don't know everything. They want me to understand, but I don't think, I have to say that my doctors probably don't understand me very well.
Isn't that interesting?
It doesn't mean that I have a negative feeling against my doctor, but
not that they're not giving you good care, but still, yeah.
Right. So I don't have a real high expectation that the doctor is going to understand every single thing about me, actually. So it's same thing, for me on the doctor side, and, patient is not telling everything, and patient thinks different way, but still we need to get the business going, and it's a fine balance, and it's a dilemma, but ultimately, like laboratory data, imaging data, they generally they don't lie, and then research or standard care, those scientific things is quite generally is more solid. So the common ground that we could really communicate effectively always go back to research related items, or talking about what it takes to live at the fullest extent. And sometimes it has nothing to do with research. It's really about how do you want to really, live your life? How do you want to spend your time? And so I'm a little bit more lenient about, giving flexibility to certain things, particularly for people who have metastatic disease, because I prefer for them to live well rather than focusing on this, sometimes what I call some stupidity that happens in the healthcare system and what we offer. So,
Well, that's an interesting topic because, I'm very passionate about research and I know you work too. And I always love it how you blow up my phone and say, hey, can you give me some money? Honestly, it gives me energy. And so, but I love that because you will literally text me saying, hey, there's something I want to do. And I'm like, I love it that you think of me that way. You think of the IBC network that way. And under the pandemic, I hate to say because of COVID, because it was way more than COVID. Under the pandemic, so many things happened, hospitals shut down, different support systems. Patients were being dropped off at the curve to come get their treatment. A lot of physicians and medical teams left for various reasons. And a lot of research was, I feel like, stymied because we weren't getting to get together to talk about it. I know we did things virtually, and I'll say this at the beginning, and I want your thought, is I've been in those research meetings where I've seen somebody across the room make a noise or, lean in all of a sudden excited about something, and someone noticed it, and it just went down this whole rabbit hole. That doesn't happen virtually. What do you want people to know about what's happened the last couple of years about research? What is kind of the takeaway that you want them to see? And what do we need to do to help get it back on track? Because I personally think things have slowed down and cancer does not care.
right. And I mean, I don't have a quantifiable data that it really slowed down, but there are kind of good thing and bad thing going through a pandemic. Okay. So the good thing is that, people have gone through more remote, right? So remote gives, more time because you don't travel anymore. So I have to admit that I gain more time by being remote because I don't have to move around and I could do more. And then we now are the situation that when you do like Zoom, we have equal opportunity to talk with anybody. So I could hear better with people who's participating in the meeting if they participate. Of course, there's a if, right? But if we do the Zoom correctly with a video on, with a high quality sound, it really helps me to understand. In the past, if you're sitting in a room and you're sitting more in the end and it's sitting in the front, sometimes you hear it or so you can't hear it and you can't do the chat. And so technology does matter, but it is something that interesting that pandemic really shown that people who never really understand the technology. So they say they understand, but they really don't understand. It took almost 2 years to make sure that people are, proficient with like using the Zoom. But even with Zoom, now the only thing they know is push the button, and other than that, they don't know anything about it. But
I remember in the beginning, we were constantly telling people to mute their microphones because we could hear, all the things in the background. But one thing I see with us being virtual, it's made us think about how to do things differently. That's one thing that I think that came out that was good.
Correct. And then so now what we're challenging is that how to form that right culture. So one of the challenge of the negativity of this remote approach is it's hard to build a team culture. It's easy to team, but it's difficult to create a culture. And if you and I know, and I kind of know how you interact with people. So even without through Zoom, I could simulate or simulate what you have in the past. But if you got a new member and suddenly you come into this settings, you just don't know the person very well. So I think we really have to do more like retreat or some kind of having a lunch with no agenda just to get to know each other, because personal touch and personal communication does matter to create that team culture. And that's the biggest challenge. So I think collectively to have a more, working together and having a major collective impact, yes, the pandemic has put it more challenging than before, but I have confidence. I think I'm a little bit biased because I'm more technology oriented. So I think that there will be more new generation who is more technology oriented and, using any kind of new technology to communicate. They're so used to it. And then we figure out when we should have lunch or when we should have dinner. And I think good things will come, but I think there has been some slight slowdown because of the pandemic.
I think there's been slowdown, and I think it's interesting how many researchers are introverts. And I always thought of an introvert as someone who's just shy. And once they got to know me, they wouldn't be so slow to speak. And I realize it's a whole different process of thinking, and I understand that more. And so I think it's been interesting that I wondered, would an introvert be willing to talk in a Zoom meeting? And I find that they put the still picture up and they're not live like you and I are, but they're typing in the chat when they wouldn't have said anything in the meeting.
Right, correct.
Physically. So I see pros and cons, and I'm just grateful that people worked around it. But I was just kind of curious, what you think the future is going to look like, and what do we need to do to facilitate research? Because most people think that all the pink money goes to research, and very little does. We know that. And we really need to get behind research. So is there something you would like to see out of the IBC community in particular? That's a big question that you weren't expecting.
There's need for new blood. And then when I say new blood, we need
You mean
more
in the research leadership area? Okay.
leadership, but just in generally investigators and people who support. So I think we have a lot of people who's interested in IBC, but the player is somewhat limited. And then
well, and the way the grant system works, if you don't get a grant, you don't get a job. So it's hard to encourage someone to go into IBC research when it could be a dead-end career.
That is correct. Because if I was, so that's where, like your donation or trying to create the next generation of oncology is very important, because we need generation changes and we need new people to come in. And so, I'm leaving IBC program at the height of my, tenure, and it's I wasn't unhappy about it. I mean, I'm happy with what I'm doing, but I decided to leave, and I had different reason to leave to Hawaii, was because different agenda, testing my leadership skills and testing things that I learned at a much more grand scale is what I was interested. So that's the reason that I'm going to a different path. But also I have confidence at a certain level that strategically, what do we do next? I put the real rail there, working with many people. So now it's implementation time, but sometimes it's good to steer up by leaving and then getting new blood. And we have new faculty coming in, and we should look for more new people. And when we look new people, you want diversity for not just gender, age, okay, and then different geopolitical location, and that's what it's needed. And you cannot be doing the same position, you can't be in the same position for too long, because it's like U.S. presidency, right? We only do 8 years, and then they only do 8 years, and you don't want president to be there for 12 years and 15 years, and usually things gets corrupted. So I'm not saying that IBC program is corrupted, but I will guarantee you that there will be some new changes coming in a good way because of my departure, and that's how things work, actually. And it's always,
I think that's really kind of you to say that, because it is important to me that people know that you were happy there. But also, I think we do need to be challenging ourselves for growth. And if we're doing the same thing the same way forever, I mean, there's one major pink organization that I'll not name, but they've done a fabulous job of, talking about cure, early detection, cure. But I would like to see that conversation grow up to the next level. And where people now say, okay, we know about breast cancer, so let's get some funding into research, or let's also talk about the fact that women present with different kinds of cancer, or they can get cancer they're pregnant, or they can get a cancer that shows, like IBC, because we're always taught, you can't see it, you can't feel it, doesn't hurt. So I think a lot of people with good intentions have been stuck in the same place for a long time. And it's scary to take a risk. It's scary to make a change. I mean, I'm sure you're not suffering at the idea of going to Hawaii. It sounds amazing, but you're taking on some scary change.
Yeah, correct. I mean, uh, the word I don't know if you know how, my style of leadership, but I have this concept that I allow control chaos.
No, I do know your style because I've worked with you on committees. And what I love is you don't micromanage. You welcome all ideas, which is part of the chaos. You let it come at you from every way. You don't say no right off the bat. You don't say, oh, we've never done it that way. And you're open to ideas. And then you are what I call a kind of a soft touch, and you'll say, well, go with that. Let me know how it's going. Touch base with me. And I think, and you give people permission to have ownership, but they still know you're the boss, which is good because you need that mentorship.
Mhm.
And I see what a loved mentor you are. I've seen you when people come and they mentor with you, and then whenever they leave, you always give them a cowboy hat and you get ready to sign it. I see how much they treasure that hat. And I was very excited because I got to meet MD Anderson one day, and I was one of the first people to sign your hat because I didn't get to, your party couldn't be open because
It
of
was
COVID,
really
I
nice.
understand, but I did
It
get
was
to sign the hat. So the fact that when you give that hat, I've seen you give it and how much they treasure it, let me know what they thought of you as a mentor.
Mhm.
So I do know your control chaos.
Right. And I think that this concept of control chaos in team development is extremely important. And
Well, and I've seen people flourish under you. You've got some students that have just won amazing grant awards and are, just blowing the doors off of things. That is in part with you to be their guider.
right. And
Well,
they teach me also. So, the mentorship is not one way. It's a peer, you have to understand that people think mentorship is one way, but it is not. It's basically, you learn from the mentees actually. So you need to have that attitude of willing to learn from anybody, regardless of what position they are or experience they have. There's something always to learn. Yeah.
oh no, I understand that. I'm a chair of a local library in the little town I live in, and it's not a city library, it's a private library because our town's too small to have one. And I've been really working hard with the staff about understanding there's things I want to mentor in them. And now that they've never had that before, and now that we've had a year of that, they're like, oh, I get it. And they're getting that I'm learning from them. And so it's worked. When you talk about going to Hawaii, you've mentioned that you're taking some of the research with you. And I said
Mhm.
earlier, because a couple people called me and go, well, he's taking the research with him. Does that mean it's stopping? No, it's not stopping. MD Anderson's had a dedicated program for a long time. And as you said earlier, it gives more space to grow at MD Anderson. And then you're going to take some things with you that you're going to be
Mhm.
applying and working with MD Anderson, Dana Farber, and others as it goes. Is there anything you want people to know about that research before we wrap up in a little bit?
No, I like people to be confident that, I think it's not take or not take. And then it's just that I'm diversifying by my new position and new opportunity because by going there, the purpose is not to enjoy the beach, but you meet new people, you
I
meet
hope
new,
you do a little bit.
yeah, of course. The idea here is to interact with new people, and that gives a new perspective. And then and the goal here is not to lose that connection with people who been working for close to 30 years, right? So, and that's how things work. And so I don't look this situation as anything negative, and rather I think if I am committed to continue to do IBC, if my group continues to be committed, and I think new things will happen, and probably 5 years from now, we will say that, hey, that move was the right thing to do, and it's really helped, the Hawaii side, and it also helped the MD Anderson and even other like Duke and Dana-Farber. So
This will air before the San Antonio conference. And I know IBC, it gets presented strongly in the poster sections, but it doesn't get presented from the main stage. But this year, MD Anderson is hosting an international symposium. Do you want to speak a little bit about that? Because people can, and I'm very excited. I'm interrupting myself. I'm so excited. We have 18 patient advocates signed up for that.
Yeah.
I am so thrilled. So people need to know that when you talk about this conference, those things are on the IBC network calendar. If you have a physician or a caregiver, or nurse or something wants to take it, it's all available virtually. The IBC network donated to make sure that virtual component was there. We felt very strongly we wanted everybody to learn, but also patient advocates can sign up for a very low fee, and that is, I think, one thing I want. I know it's hard when you're a patient and you're going through all the things you're going through, but maybe for the ones that are maybe a little further out and are well, we really need to get those people on board with advocacy. I think
Right.
sometimes we're waiting for a celebrity to speak up or some one rich person to donate a lot of money, but I'm a big believer in the power of one. So we need to get our advocates together. Could you tell them about the conference that MD Anderson's hosting? Because you're in charge of this.
Right. So I'm the chair of the IBC conference. This is the 7th international IBC conference working with IBC International Consortium, but MD Anderson is the main host, and we co-host is IBCIC. So this is really to learn about aggressive breast cancer, not just IBC, but dominantly IBC. And it will brings up, new research, new opportunity to meet new people, and some of the ongoing research will be presented. So it is a great opportunity to me. I think it was December 2nd and the 3rd, and we welcome everybody to join. We have a platform that allows to post your question, and if you're attending virtually, people could chat and send message to the speakers. So, and this happens every 2 years, and we're very proud of bringing back the first one was actually done at Houston, and we're proud that this is coming back. And this is, as I said, goes back to the first thing we were talking about. The most important thing in collaboration and advancement in research is to create that right culture, right? So many of them are coming there to meet in person, and I'm confident that we could create a great culture and that we would like to see. And then when we have patient advocates or patients or caregivers joining in, it makes it becomes a much more richer experience. Yeah.
Now, and one of the things that happens, because this conference is the international conference, it happens every other year. What they typically do, what I've seen is it happens 1 year, then 2 years later, it happens somewhere else in the US, and it goes overseas, and then it comes back. So this year, it is at different times of the year, depending on the host. And since MD Anderson's the host year to year, it made sense to do it just before the San Antonio symposium. It's always that first week of December because you've got a lot of doctors traveling here. Now, one of the things that happens at that conference is, if I understand this right, is that you confirm, because I have people see, oh, well, I saw a paper, and it quotes all these things that are 10 years old, so it's old. No, I try to explain to people what you do is you bring forth new research, you bring forth, you talk about the new chemotherapies or the new practices, but you also confirm what has been viewed as standing that still works. I think people think that means it's old. No, just because something's still working and it's still working doesn't mean it's old. It's the current good standard.
Right.
How would you explain to a patient or a doctor who doesn't see the value in this, what happens at the end of that conference? Because isn't there a paper published normally? Is there an updated paper published or not? Or was it just the 10th anniversary?
From this meeting? Yes, usually we have some proceeding coming from the conference. We have not yet decided what exactly we're going to do this time, but we hope that we could do something, but it's still an ongoing discussion. Yeah.
Well, you got to see what's presented too, to know what you've got.
Correct.
And
so I will be presenting the best IBC practice, and that would provide you some of the idea of standard, but the standard even has nuances, and people, it's easy to say that you give chemosurgery and radiation, but there are many factors that goes in, so it's complicated. decision making. And that's one of the reasons that at MD Anderson we have what we call the multi-team clinic, and all the discipline will get together. If you didn't go through that system, we have a quality assurance meeting on Thursday that we created. And this allows to make sure that whoever sees the IVC, we still have a check system so that our IVC physician and radiologists agree with the decision that's being already decided.
And that personalized medicine is really important, because I've had people who write me and they'll say, well, since you did well, I want exactly what you had. And it's like, no, I'm triple negative. It might not fit. And by the way, there's 3 new drugs out that weren't there, that work for triple negative, that weren't there. So, it truly is personalized medicine,
right.
Based on so many factors with you. Well, I'm going to miss you a lot, but so I'm going to have to find a way to justify going to Hawaii to see what you do. But you are the most accessible person in the world. You're very, very active on Facebook. You're very, very active on Twitter. And we'll be sharing all your information so people can follow up and follow your research. Is there any parting message you want to give them before we go? We've been on the air almost an hour.
Come and meet me in Honolulu. So it's a nice place to visit.
I would think it is. Well, I am really proud of you for taking on this risk. It would be in some ways easier to not take a risk, but you're going to expand something that's going to make a difference. I know you're very personally driven from your own history as a patient, some of it based off your ethnic model of yourself personally, but also some of the accomplishments you want to achieve for the IVC world. So I'm really proud of you.
Thank you. I really appreciate all the support and all the donation you have provided to the program. So,
well, I plan to be sending out some appeals to help to support the research that you're going to be doing in Hawaii. And you can keep blowing up my phone and saying, hey, I want the IVC network to fund something, because I love that challenge.
Thank you.
Well,
thanks
my love to you and your family. And I'm looking forward to talking to you in Houston in December. And I'm sure I'll see you in San Antonio. And then I'll wave at you from Texas to Hawaii.
All right. Mahalo.
Take care. Bye-bye, sir.
Bye.